registering for this session. We hope you're going to find it useful. My name is Lucy Warner. Some of you will recognise me from the revalidation support team. I've now transitioned, as many of us have, to NHS England. The point of today's session really is to think about consistency and to think about fairness when we're responding to a concern. There was a question I think raised earlier in the Q&A about the difficulty some doctors have in finding work after a period of remediation, in accessing remediation, and in the approach perhaps that we take to different types of doctors. So those are some of the things we want to pick up in the session today. I'm going to introduce you in a moment to Stephanie Bown, who is the new director of NCAS, and she's going to talk to you a little bit about what NCAS has found in terms of the types of doctors who come and who are referred, and some of the things that they've learned, and some of the new ways of working that NCAS are thinking about moving into the future. And then I'm just going to talk to you for a short while about some of the things we've been doing centrally to consider consistency in responding to concerns, and some of the things that we're doing within NHS England as a designated body. And then I'm very pleased that we have Deji here, I'll let him introduce himself in a moment, who's going to kind of lead us in discussion really about what are the issues as far as you're concerned about consistency and fairness. Is it important? What can we do about ensuring it further? I'm hoping that what we'll come out with at the end of this session is some ideas about what we can, if it's important to you, what we can do nationally in relation to consistency, what we can drive through the various stakeholder groups, through the RO networks, how the ELAs can help us. We've got Andy Lewis here, who's head of the ELA. The other people who are clustered here, just to introduce them, is Peter Dixon, who I'm sure many of you know from NCAS, and Karen Wadman. So they're all here to help facilitate the discussion. Before I hand over to Stephanie, I just wanted a quick show of hands really about which sectors you're working in. So can I ask firstly, anyone in secondary care, can you put your hands up? The majority actually, I think. Primary care, and the independent sector, locum agencies, small bodies. Excellent, community trust. Excellent, so I'm going to come to the others, sorry about that. But you're right, because there's so few of you actually that aren't there. Yeah, but you do tend to get forgotten, you're right in the middle. Okay, thank you, that's really helpful because it helps us kind of frame the way that we raise the discussion later. So without further ado, I'm going to pass over to Stephanie. Stephanie's been around nearly as long as I have, but I'm going to let her introduce herself. There are some seats at the front if people want to come forward. Do come forward.
Do you want that on? Is it working? Can you hear me? Oh, can you hear me too loudly? Is it a bit much?
Shall I try it without, or do you prefer it with?
I think we need it because of the cameras, actually.
So I'll try not to shout into it. Well, thank you very much indeed, Lucy. I'm really absolutely delighted, if not a little bit awestruck by being here. I've been at NCAS for about 10 weeks, not that I'm counting. But by way of background, I have got over 20 years' experience of dealing with, dealing with doctors whose performance has come under question, and they might have faced regulatory or disciplinary investigations since I was at the Medical Protection Society for approximately 20 years. What I'd like to talk to you about is really just refreshing awareness of what NCAS's services are, what we're doing about them looking forward, and also sharing a bit of the experience we've had about who gets referred and why, and open that up for discussion afterwards. I'm really grateful to Karen and Peter who've undertaken to keep me on the straight and narrow and not mislead or misrepresent anything. So, as you probably are very aware that our core services, which are and will remain available without charge to referring bodies, are largely, first of all, the advisory services. And with the advisory services, we have got a huge wealth of experience around human resources, legal, employment law and clinical expertise that NCAS can draw on. And we have recently reinforced some of our employment law expertise by having calls triaged by panel lawyers from the NHS Litigation Authority. I should just actually emphasise that since April 2013, NCAS now has its permanent home as an operating part of the NHS Litigation Authority, so that's where we live. And that advice can be either just general approaches to resolving concerns about professional practice, or it can be very specific advice on an index case, an index practitioner. And about 60% of our calls are advice calls that can be concluded just on the basis of one or two conversations, advice and correspondence. We also have, and you'll be aware of, the interventions and assessments that we provide. I think historically, NCAS has been thought of as an organisation that provides only one kind of incredibly robust, platinum-plated assessment. And there has been a sense that it's been slow, complex, and possibly even disproportionate to the needs of an index case. But what I really want to tell you about is that the nature of the interventions that we're now able to provide are much more modular. So it might be, and tailored to the needs of the referring body. So these can include just a record review, a records-based assessment, which includes interviewing the practitioner, behavioural assessments, occupational health assessments, issues around communication skills, as well as the clinical assessments. And of course, you can have either those in part or in its entirety. And it's the entirety which is the traditional, what you might think of as the traditional assessment. In terms of our educational services, we really do have a lot of skill and knowledge that we want to share with referring bodies. We've provided masses of training on case investigation, case management, how to manage performance concerns. And going forward, we're looking at how we can develop new services beyond just our core services that referring bodies might be prepared to pay for. Because that is, the direction of travel is that while our core services will remain available without charge, we want to think about how NCAS can move towards a self-funding model. And, but I would reassure you that those core services are available to you. So, the first thing is at the outset, what we will ask you about is what exactly do you want to achieve to resolve this issue, and how do you want to get there? And I think this is really about having quite detailed strategic case management discussions at the outset of the case to make sure that we properly understand and that you properly understand and thought about the nature of the problem that you've got and what you can do about it. In December last year, we commissioned an independent review of NCAS's services from Deloitte. And Deloitte recognised in conversation, in dialogue with a lot of referring bodies and our customers, we were recognised as a trusted and valued source of advice and intervention, but also identified what opportunities there are to improve our services for you going forward. So already, we are seeking to make sure that our interventions and our advice is much more flexible to meet the needs of each individual case and each individual referring body. So this modular model of interventions. And also being more proactive perhaps and about actually signposting to referring bodies where they can find those interventions to help resolve concerns early. We are aligning our advisory services with area teams and with NHS England regions so that we're going to be able to build on customer-focused, personalised links with your own name. You should be able to know who the advisor is for your organisation. The feedback on our assessments was that they were too long and too slow, so we're really looking at those assessment reports to be shorter, concise, so you can actually read the first 2 pages and get to the nub of it, but without diminishing the robustness of the evidence that supports those assessment reports. And we are working really hard to make them much more timely. We should now be able to move from an agreement to assessment to actually starting an assessment within 3 to 4 months. But we have to keep our eye on that, because if it's taking more than a year, that's just not a service for you. And we are in close conversation with NHS England about what the role NCAS can have in the emerging context of professional support units. So, just a little bit of background then about where our referral comes from. Our largest referrals are from acute trusts, and 83% of acute trusts use NCAS. About 62% of mental health trusts, and 93 to 95% of area teams refer cases to us. And we have a remit for addressing concerns about doctors, dentists and pharmacists. The overwhelming majority, some 90% of our referrals concern doctors, 7% dentists, and 3% pharmacists, for those who've got the maths right. But we're really looking at whether we should be increasing our profile and our availability in the field of dentistry. The total number of referring trusts has remained reasonably constant over the past 5 years. We get about 1,000 referrals a year, but interestingly, the pattern of the source of referrals has been changing, in that the number of referrals we're getting from primary care over the past couple of years has diminished, and the referrals we're getting from acute care, hospital and community care, has really increased quite significantly, and we could all speculate about the reasons behind that. But I'll leave that perhaps for discussion later if we want to. So, how effective can NCAS be? Well, this is looking at 260 of the more serious kind of cases that have been referred to NCAS, where we've been involved. It's over a 5-year period. Some of these will have involved a detailed assessment or a modular intervention, but it's certainly cases where we have been involved in creating and supporting the implementation of action plans. And I think it is good for us to be able to show you, I think, that in nearly 70% of cases where we've been involved in creating an action plan, the practitioner has returned to work. What about your relative risk of referral to NCAS? And I'm talking now about medics, about doctors. And this is looking over referral rates over an 8-year period from 2004 to 2012. And over that period of time, the average risk of referral for a doctor to NCAS is about 5 per 1,000 per year, where the dark black line rests. But it's interesting to look at different specialties having higher and lower relative risks. And in particular, you'll see that psychiatry seems to capture a higher proportion of referrals to NCAS than would be than the average, and also obstetrics and gynecology. So can you see? And we have done some work to try and understand why that is. And it would seem that this will tie in with my last slide, which is about demographics and in relation to place of qualification. And it seems that in psychiatry, as a cohort, we have a higher proportion of practitioners who qualified outside the UK, non-UK and possibly non-white practitioners in that group. But interestingly, although they have a higher risk of referral, they have a much lower relative risk of actually being referred for an assessment. So I'll leave that with you. What are the nature of the concerns that are referred to us? This is what the referring body will say is their area of concern. And again, this is looking at over 5,600 cases over a 7-year period. And obviously there is overlap. It's rarely just one issue, but you have issues around behaviour and misconduct in 58% of the cases, clinical concerns and governance issues in about 58% of cases, and health concerns in 21%. And although the bit that's missing from that are concerns about the workplace. And of course, when NCAS gets involved in a case, we'll look at workplace issues as well. But it's unusual for a referring body to say, you know what, the workplace this practitioner is being exposed to is a real problem. However, since 2007, NCAS has actually had a rigorous way of capturing the concerns and arising out of cases. And you'll see that what we get from this is clinical concerns in about 47% of the cases, involving issues around record keeping, diagnostic treatment decisions, departures from protocols. We were hearing about that this morning, weren't we? Governance issues in 29%, so turning a blind eye to complaints, infection control. And behaviour other than misconduct, the commonest issue here is around communication, both with patients and with colleagues, and bullying and harassment. 21% health concerns, and look here, we find that in 7% of cases there are work environment situations, and in 3% there will be background personal issues. Overviewing then the demographic differences, when we're looking at fairness and consistency in a role of a national organisation such as NCAS, what have we found out about different patterns of referral? Remembering that the average rate of referral for a doctor would be 5 per 1,000 per year. Well, if we look at our referrals, you'll see that men are much more likely to be referred than women. I just leave that with you. What about the stage in your career? Well, it's perhaps not totally surprising that the referrals seem to go up at later stages in career. And it will be interesting to see if this changes going forward as we have revalidation in place, because maybe some of this is reflective of practitioners who haven't been able to keep up to date, and then something, they've fallen off the tracks and then get the referral to NCAS. Then finally, there has been much talk about whether there are ethnicity issues that predispose a referral to NCAS. And what I would really like to emphasise is that what seems to matter in terms of relative rate of referral to NCAS is place of primary qualification. So if you qualify, there is no significant difference in referral to NCAS from white and minority ethnic practitioners if they've qualified in the UK. The difference is really in relation to practitioners who come to the UK having qualified either within the EU or outside the EU. But we really need to keep an eye on that. That profile, I think, is similar and reflects the findings that the GMC published in 2009. I can see Neil in the back there. So we must keep an eye on that, and I think what it tells us is that it's how important it is for us to be available to support international medical graduates, as well as practitioners who are transitioning through later stages of their career. And I just leave that there, really. These are our contact details, and I really welcome the questions that you will put to us and your thoughts, and going forward, your feedback about how NCAS can be providing you with the service that you want and a service that you will really value. Thank you.
Thanks, Stephanie. I'm going to suspend questions until we get to the discussion stage. I do apologise for the overcrowding. We were expecting 60 of you, and clearly there's more. So it's probably getting a little bit hot in here, so do feel free if you need to open the door, and I can see there's some more chairs coming in. There are a couple of chairs just up the front here as well if anyone wants to make their way forward. Did you take the clicker, Stephanie? Yes, you did. So what I wanted wanted to do is just give you an idea of the things that we've been doing nationally, and I'm going to whiz through this a little bit so we've got the majority of the time for discussion. But firstly, for anybody who doesn't know, we have now published the policy around responding to concerns in responsible officers. This is clearly important to you. At some stage, you or a colleague may have a concern raised about you. We've had 4 concerns currently that are being investigated through the regions, and they are following this policy through. So it is important to know what the policy says, the process it applies. The principle really in the policy is around encouraging organisations to take responsibility for investigating where it's appropriate and for assessing the problem where it's appropriate and doing what needs to be done to remedy the problem. But clearly, where a formal investigation is required, your prescribed connection is to NHS England, and NHS England will manage that investigation process. They'll work with your body, they'll work with your chief exec and whoever else your chief exec nominates to be involved in that, but the responsibility does sit with NHS England for carrying out that investigation. And the process the policy describes how that process will work. So just to make you aware, if you haven't seen it, please do take a look at it. The other thing I wanted to mention is case investigation and case manager training. I'm sure a large proportion of you in this room may well have been through that training. As you can see, we have trained a considerable number up and down the country. And really that was about developing a national programme, national standards, national competencies, national expectations of how we would anticipate a case investigation and case management should be carried out. We've had some excellent feedback for that, but clearly we have around, I think, 700 expressions of interest now of people still wanting to undertake that training. So we do have some plans for future training. I can't tell you that that will be free, as it was in the last 2 years. There will be a cost related to that, but we will be putting on some further training as we move through the year. The other thing that we are working towards is a database of trained individuals. We know for some small organisations it is difficult to identify a trained investigator, or in some cases you need an investigator that is separate from your organisation. So we have people who've already identified themselves as willing to work in other organisations, and we will be establishing that database through the PSU infrastructure as we move forward, so that you will be able to contact the PSU and find a trained case investigator willing to help you should you need to. And the other thing that we would like to do through the PSU infrastructure is build on the networking opportunities, build on the opportunities in the same way that the RO networks have worked, but for case investigators and case managers to talk to one another, to learn from one another. And we think that will help us drive that consistency, drive the learning, and think about further training needs, further development needs in this area. Terminology. When we started this process a few years back, I heard so many definitions, people saying one thing when they meant another. What we've tried to do now is come up with a consistent terminology in relation to terms used in responding to concerns. We have a glossary, which now sits on the NHS England website. That was developed with a range of stakeholders, with the GMC, with the Academy of Medical Royal Colleges, with NCAS, and with a variety of other people involved, agreeing what those definitions should be, what we meant when we said clinical supervision, what we meant when we said mentoring, etc., etc. So please do have a look at that glossary. I'm going backwards, so I think that's always a good way to go. The categorisation framework and the definitions of levels of concern, they were developed some time ago, but we've republished them recently, because I think for those of you that have been filling in your AQA, the assurance of quality, I've forgotten what the other A stands for, one of the questions was around the numbers of concerns you had at each level. Now, we had defined the levels some time ago, but we've republished those definitions on the NHS England website, describing what exactly we mean by a low-level concern, a medium level and a high-level concern. And we've also provided a categorisation framework that helps you make that decision, helps you decide whether this is or is not high, low, medium, and helps you also decide whether trigger points are for decreasing that categorisation or increasing that categorisation as you go through the process of assessment and investigation. So please, again, do have a look at those resources on the NHS England website. If they're useful to you, use them. They are guidelines. If you have your own way of categorising, your own way of doing things, please don't feel that you have to use the NHS England examples. And then I want to talk a little bit about PSUs, professional support units. This was brought up, I think, in the main room earlier. Stephanie's alluded to it. I'm not going to go into huge amounts of detail here because there are a number of discussions that are ongoing, but suffice to say that we are enthusiastically pursuing a professional support unit infrastructure. And this is the definition of what we mean by that. So it is that kind of hub of expertise and knowledge that allows us to work in a consistent way and hopefully maintain a safe, high-quality workforce. Some of the things that we're thinking about is essentially a central umbrella infrastructure that will deliver, if you like, part one of the responding to concerns pathway. And by that, I mean the kind of assessment part, the investigation part, and the coming to a decision part of what needs to be done next. Now, organisations are all different. Some are small, some are large. Some will need more help with that, and some will need far less help with that. But what we are hoping is that through this infrastructure, we will have the availability to all designated bodies to make use of those assessment and investigation tools if they so require it. So that's the key really in relation to part one. Part two of the pathway, which is really about putting things right, remedying the situation, offering interventions and support, our concept is that we will develop a framework of indicators, quality indicators, and that we would expect any person delivering intervention and support be able to demonstrate that they meet those indicators, that they are delivering a high quality remediation support service, and that they would then become part of that signposted umbrella infrastructure and be able to deliver support locally. We are aware that there are some fantastic pieces of work going on in terms of remediation and support in some of the LETBs, in some organisations, in some commercial organisations as well. And we don't want to lose that. We want to make use of that wherever possible. We're also aware that there's some big variability and there are some gaps. So also what we want to do is try and encourage people to come forward and offer their services. So we're hoping that that will be the case, but that's going to take some work. And that's work that's going to pursue really through to the end of this year, at the very least, perhaps much longer. I think we have to kind of outline the benefits of the PSU in the specification paper, which a lot of you will have seen. We've had a huge amount of feedback on, so thank you to that. So I just kind of wanted to put those up there just to reflect on why we think it's important. We do think there is some real gains to be had in terms of learning from one another, in terms of reducing costs, reducing time of people being suspended, and hopefully lots more doctors returning to safe practice where possible. And then just a little few points really on NHS England as a designated body. Those of you who are in area teams, you are all part of NHS England, we are one body, and for us as a body it's important to do things consistently. As it is for those of you in different types of organisations, you need to be consistent in the way that you approach things, be able to demonstrate that. So what we are doing within NHS England, just a few things, we are doing some further training of the people who sit on the groups that make decisions about primary care performers and other doctors with a connection to NHS England. We are training them in the way that they make those decisions. We are looking at how they make those decisions and what they base those decisions on, so that we can be fairly confident that a decision made in Newcastle will be justified in the same way as the decision made in Norfolk. It may not always be the same decision, but they will be using the same sort of principles, the same sort of processes, so that we can be assured of that. Now, what we are going to do to help assure us of that is run a pilot looking at some case investigation portfolios and looking at how different area teams might apply the categorisation framework and how they might come to those decisions. And so far we've got about half a dozen area teams signed up to that, and we're about to go out and see who else wants to be involved. We're also about to publish the revised policy for dealing with primary care practitioners. And again, this is about consistency, because that policy will apply to all primary care practitioners, not just doctors. So that policy will also cover the family practitioners and the dental practitioners and pharmacy contractors. And as part of that, we're also working across the area teams, and again, those of you in area teams, be warned, because I'm going to come out and ask you in the next couple of weeks. We want standard letters, we want templates, we want things that you can all use, that we can get checked through legal processes, so that NHS England sends out the same letter in the same circumstances. So we do have some consistency in the way NHS England operates. And the other thing that we're doing across NHS England is looking at the different approach area teams take currently. And much of this is based on historical work as a PCT, the approach that they take when remediation is required. So we know we have some hawks and we know we have some doves amongst the area teams. So we're looking to see what those differences are and see if we can come to a common policy in relation to remediation. So that's all I wanted to say. Oh, sorry, one other thing, the National Stakeholder Group. Those of you may remember that there was an implementation stakeholder group for responding to concerns as part of RST. We're looking to develop that now as part of NHS England, but we're looking for this to cover NHS England as a whole. So we will be looking for contributions from the other sectors. What we would like to have is contributions from each of the RO networks. So we will be writing to the RO network leads to say, could you volunteer people? We're saying perhaps 2 or 3 people from each network who would be part of the RTC implementation. And we think that this is the group that can perhaps drive forward consistency across England where it's appropriate to. Clearly you are your own organisations and you can make your own decisions about things, but there may be areas, I'm going to come on to that discussion in a moment, where consistency is important, and we'd like to identify where those are and have this group work on that.